Evening. Today, let's talk about COVID skin. What are the cutaneous manifestations of the COVID-19 infection? What are the objectives of this lecture? We all know that in the morbidity and mortality of COVID-19 is associated with cardiac and pulmonary complications. The objective of this lecture is to review the dermatologic manifestations of COVID-19, which are increasingly recognized as an effect of vasculitis versus direct viral involvement. It's also to recognize that skin lesions, while self-revolving, may be the first sign of COVID-19, and to be aware of dermatologic manifestations and complications and treatment of COVID-19 skin manifestations. Let's take a brief overview of what COVID-19 is all about. In December 2019, a new virus emerged. They said it was related to the first SARS-CoV and also the MERS-CoV, but this one was causing new cases of pneumonia in Wuhan, China. However, what happened was they found out that it had spread globally, and so the WHO declared a pandemic in March 11 of 2020. SARS-CoV-2 is a zoonotic illness originating in bats caused by a single-stranded RNA known as severe acute respiratory syndrome coronavirus 2. It's an enveloped, non-segmented, positive sense RNA beta coronavirus. The transmission is between people through respiratory droplets and contact routes. That's why we have such measures as social distancing, personal protective equipment, wearing masks, face shields, and always avoid men, the exposure of the mouth, the eyes, and the nose. Your mean incubation period is 5.2 days, and 95% of the patients develop symptoms 12.5 days after exposure. So this SARS-CoV-2 has an appearance of a crown under the electron microscope. You have the genomic RNA and 4 structural proteins, namely the spike, the envelope, membrane, and your nucleocapsid. It can attach to the host cell by binding its S protein or the spike to the receptor protein membrane. The ACE2 is the receptor on the host cell membrane with a high affinity to the SARS-CoV protein. So how does it enter the body? What happens there is that the SARS-CoV-2 enters the host through interaction with spike protein with the entry receptor, the ACE2, in the presence of your TMPRSS. There's higher binding of the SARS-CoV-2 to the ACE2, explains the increased transmissibility because the ACE receptors are found in your lung alveolar epithelial cells, small intestine enterocytes, vasculature, neurologic, endocrine, cardiac system, and the basal layer of the skin. So the skin signs may appear before the systemic symptoms or present several days after onset. So, and skin symptoms occur in 20 to 40% of patients. What else do we know? There's dysregulation of the renin-angiotensin symptoms as a consequence of downregulation of the ACE2 related to the viral entry, which leads to the decreased cleavage of the angiotensin 1 and angiotensin 2. So what happens there? So with this regulation, this is important. Remember the renin-angiotensin system and the key balance of your blood pressure regulation, your vascular permeability, and tissue growth. The ACE2 cleaves angiotensin 1 into inactive angiotensin 1-9 and cleaves angiotensin 2 into angiotensin 1-7. Therefore, you have vasodilator effects, anti-proliferative, and anti-fibrotic effects. The direct mediated cell damage is caused by the spike directly attaching to your lungs. And then for your vascular changes, what you see here, there's endothelial cell damage because by the ACE2 mediated entry of the SARS-CoV virus, and so there's inflammation and generation of a prothrombotic milieu. This triggers excessive thrombin production, inhibits fibrinolysis, and activates the complement pathway, initiating thromboinflammation, microthrombi deposition, and microvascular dysfunction. What happens here is that with the dysregulation of the immune response and hyperinflammation caused by interferon, inhibition of the interferon signaling by the SARS-CoV virus, it results in the hyperactive innate immunity, which results in cytokine release syndrome. Cytokine release syndrome would be manifested by high-grade fevers, hypotension, and multi-organ dysfunction. So this is, in summary, is the whole pathophysiology of your COVID-19 infection. These are the organs affected, but for the purpose of this lecture, we are focusing only on the dermatological manifestations of COVID-19. So what are the signs and symptoms of COVID-19? Let's go over it briefly. We know there's fever, fatigue, dry cough, breathing difficulties, myalgia, sore throat, anosmia, neurologic and gastrointestinal disturbances such as diarrhea. However, lately, with the new variant, there is no fever, there is no cough, there is no cold. So now it becomes a condition where you have to just have a high level of suspicion. In severe cases, you have dyspnea with or without hypoxemia. And a week after the onset of symptoms, it can deteriorate to ARDS, DIC, septic shock, and metabolic acidosis. You have cutaneous manifestations, maculopapular, papulovesicular, pityriasis, rosacea-like lesions, urticaria, gangrene, pseudoperiosis, livedo reticularis, pustular lesions. And the most common types of cutaneous manifestations were erythematous lesions, rash, and urticaria lesions. The susceptible population included the elderly, especially those with comorbidities, such as hypertension, obesity, diabetes, and renal failure. However, as a footnote, now that's not really true. Now it affects all ages, especially also the young, for the cutaneous manifestations. So how do you diagnose COVID-19? Again, as a review, when you have a pulse oximeter reading of below 95, you go chest x-ray with a CT scan where you see the glass appearance in the lungs. Your laboratory findings would have lymphopenia, leukocytosis, neutrophilia, thrombocytopenia. You have elevated markers of your ESR, CRP, ferritin, interleukin-6, and lactic hydrogenase. You have your coagulation indices. You have elevated D-dimer, fibrinogen, prolonged prothrombin time, partial thrombin plastin time is also elevated. You also may have thrombotic complications, your MI, your stroke, acute limb and mesenteric ischemia. You have your venous thrombotic complications, your DVT, and pulmonary embolism. Your RT-PCR-based viral RNA detection is insensitive and can rapidly and effectively confirm early SARS-CoV-2 infection. That's why RT-PCR remains the gold standard in detecting COVID-19. What are the geographical differences in morphology and the prevalence of reported COVID-19 associated skin manifestations? There was a worldwide review done, and they found that the median age for skin manifestations was 41.9 years, with a range of 15 days old to 91 years old. We have more females being affected than males, and so it's 35% for females and 27% for males, and 37% was not reported. There was more reports in the Europe and the US, rather than the Asian population. Um, with all my based on my readings, I would attribute this to also the fact that the ILDS and the AAD have come up with a global registry. So the Asian population has only reported 3.1% as of this March 2021. And pseudochilblains was the most common in Europe and US. What are the pathological mechanisms of COVID skin manifestations? The first one would be an immune response to the viral nucleotides caused by, or the viral exanthem. So the direct T cell infection may lead to a strong immune response responsible for the skin lesions occurring in the COVID-19 illness. So you have the hyperactive immune response can add to the induction of the cytokine storm or the interleukin 6. So the cytokines enter the skin and triggers your dermal dendritic cells, lymphocytes, macrophages, and mast cells, and neutrophils, and assists in the development of your maculopapular rash. So it's all because of the entry of the virus into your skin. It triggers the entry and then triggers the dendrites, the lymphocytes, macrophages to cause a reaction. And of course, you have your secondary cutaneous lesions expedited by the systemic effects of your COVID-19, vasculitis, and thrombotic and vasculopathy. And another reason why you have manifestations would be basically because of adverse drug reactions from your hydroxychloroquine, your chloroquine, lopinavir, ritonavir, tocilizumab, and azithromycin. These are the classic clinical features of the COVID-19 associated cutaneous manifestation. We have wheals, erythematous macules and papules. Then we also have your violaceous papules or your chilblain-like acral patterns, your livido reticularis and racemosa-like patterns, and your vasculitic patterns. Based on a study with the JADD, they compared what is the severity of COVID and how does it happen inside a patient who's hospitalized. So what happened there is they saw that first it begins with pernio in 84%, affecting the feet in 84 and 32% in the hands. There's burning and other symptoms. Then later in the disease, you'll have your vesicular, urticarial, macular, erythema, and your morbilliform lesions. Then later on, you'll have your purpura or more of your vasculitic lesions. So in another study, I saw that to make things simpler, we look at the classification of cutaneous manifestations of COVID into just two groups: vasculopathy, which would include your chilblain, your livido retiform or hemorrhagic lesions, which all start with an acral endothelial damage and microvascular thrombi, which may begin as mild but may progress to a severe thrombosis in larger venous and arterial blood vessels with poor prognosis. Your reactive type of cutaneous manifestations would include urticaria, exanthemata, morbilliform, and vesicular presentations, which are simply reactive manifestations to the COVID-19 virus. These can easily be controlled by your antihistamines or steroids, and usually the manifestations will resolve once the infection subsides. So let's start with the reactive type of lesions. The maculopapular eruptions are the most common manifestations. It occurs during the active phase of the disease or the viremic phase. The site includes the trunk and extremities, head and face, neck, and periaxillary areas. The average duration of the lesion is 8 days, and it may appear either 2 to 3 days before the onset or after the onset of COVID symptoms. Most frequent medications used in these patients include hydroxychloroquine, chloroquine, paracetamol, lopinavir, ritonavir, or azithromycin. So these are examples of the maculopapular rash. Next, we have the papular and pustular rash. 51% of this study had widespread papular pustular eruptions characterized by vesiculobulous or pustular lesions and indurated pigmented nodules, which appeared concomitantly or a few days after the onset of other symptoms. The etiology was inflammatory, and it is a marker of a severe disease. It happened in the trunk, usually with itching, and resolves in 10 days. Treatment would include topical steroids, antihistaminics, and azithromycin. The mean duration of the illness would be about 20 days. Exanthematous and morbilliform lesions. These would be monomorphic papillovesicular lesions occurring in the trunk, hands, and feet with pruritus. It appeared 2 to 3 days prior to the appearance of other systemic symptoms such as fever. The treatment would include topical steroids, antihistaminics, and azithromycin. The mean duration would be 7 days. Urticaria. You have your generalized and partially confluent wheal surrounded by mild erythema with moderate to severe pruritus. Urticaria was either the only symptom or preceded onset of systemic symptoms by 24 to 48 hours. The rash appeared within the active phase of the infection. It's inflammatory in etiology and has a better prognosis, although it would be distributed all over the body, including the trunk, face, and extremities, palms, and shoulders. It usually subsides within 1 week of treatment. And again, treatment would include topical steroids, antihistamines, and azithromycin with a mean duration of 4 days. So these are examples of urticaria. Urticaria was known to be the third most common skin manifestation. It was also the hypothesis of how urticaria was induced. It was the virus-induced mast cell degranulation whereby SARS-CoV-2 enters the vascular cells via angiotensin-converting enzyme 2. There's deposition of the antigen-antibody complexes, which leads to complement activation, resulting in mast cell degranulation and bradykinin release. Vesicular rash. What happens with vesicular rash? So you would see that this occurs in the trunk, and they're small and monomorphic, and it is preceded with after other symptoms. Vasculopathy. This is the second group of cutaneous lesions, and we begin with petechiae. Petechiae rashes had purpuric lesions up to 2 millimeters or areas of vasculitis with or without fever. It's associated with more severe cases of disease and presented with high D-dimer and C-reactive protein. The vascular pathogenesis was due to the direct viral replication in the vascular endothelium, leading to microvascular thrombosis in the skin. So what happens there is that they're here. So this is example of a petechial rash. So the theories is the lymphocytic vasculitis is caused by the viral particles in the blood vessels, which is the response to infection. So there's Langerhans cell activation, vasodilatation, and spongiosis and keratinocytes become also the secondary targets. Livido reticularis. So what happens here? So remember that petechiae and are small subdermal hemorrhages, while the purpura are the larger variants of this. Livido reticularis. So this is presented later in the disease course and were accompanied by elevated levels of D-dimer and fever and difficulty breathing. There are late lesions in older patients, an indicator of more severe disease. The vascular pathogenesis was due to the direct replication in the vascular endothelium, leading to microvascular thrombosis in the skin. So these are examples. So what happens here is that there's a vaso-occlusive lesions, which are the least common, affecting the elderly patients. But these patients were noted with a higher risk of severe pneumonia and associated with a higher mortality rate. So here, next, chilblain. So chilblain affects the fingers, the elbows, the toes, ankle surfaces, lateral sides of the feet, and the only clinical symptom in the majority of younger patients and indicative of a mild disease. The COVID fingers and toes are painful or itchy, and the vascular pathogenesis is due to direct viral replication in the vascular endothelium, leading to the microvascular thrombosis in the skin. And the mean duration is 15 days. So these are examples again of chilblain of the fingers, toes, and feet. Telogen effluvium. I think this doesn't belong to either the reactive or um, the vasculitis type of classification. However, I've included it because I think it serves a lot of interest. So what happens? It occurs a few days following the onset of the systemic symptoms. It's diagnosed by your pull test, your trichoscopy, and your scalp biopsy. It appeared suddenly in patients who had some pre-existing hair condition like alopecia areata and androgenetic alopecia. The hypothesis of pathophysiology of telogen effluvium is hypoxia and localized follicular constriction. Another thing that would happen actually was you would have also androgenetic alopecia, and it was called the Gabrin sign. The androgenetic alopecia was related to SARS-CoV infection as both were considered to be androgen mediated. In Spain, 71% of patients who had SARS-CoV-2 pneumonia had androgenetic alopecia versus healthy men had only 31 to 53% of AGA. It's hypothesized that AGA as a predictive factor for increased COVID-19 severity and contributed to the development of the anti-androgen effect for SARS-CoV-2 infection. The Gabrin sign was named after the first American physician to die from COVID-19. It has been proposed that a transmembrane protease serine 2, or the TMPR SS2, is essential for the viral spread and pathogenesis. It may cleave the ACE2 enzyme for viral entry, and the androgen reception activity is required for transcription of this gene. There's higher prevalence of the androgen alopecia reflective of a heightened androgen activation that may be contributing to the disease itself. What are the treatment algorithms in a nutshell? For reactive types, where usually we just have pruritus and erythema, we just give our antihistamines and topical steroids, macrolide antibiotics such as azithromycin, and for vasculopathy, we have your purpura, petechiae, and vasculitis. We would work up with our partial thromboplastin time, activated partial thromboplastin time, lactic dehydrogenase, ferritin 2, ferritin, C-reactive protein, antiphospholipid, lupus anticoagulant, and the D-dimer. Oral steroids should be given with caution in patients with elevated D-dimer because steroids cause immunosuppression, causing increased viral shedding. What are the take-home points of this lecture? The cutaneous manifestations, although in low percentage, are presented in patients with COVID-19 and should not be ignored by the clinicians. Given the high mortality of the infection, timely and accurate identification of the relevant cutaneous manifestations may play a role in the early diagnosis and successful management. And recognition of such early signs and symptoms of the COVID-19 may enable identification of cases missed when relying only on the core symptoms, the fever, the cough, the cold, which don't exist. Now with more variants, sometimes the patient just feels lousy and then it's COVID, allowing preventive measures to be put in place to minimize further spreading of infection. These are my references. and thank you for listening.